Welcome back to the deep dive. Usually when we crack open a stack of medical literature, especially exam prep materials for things like the USMLE or surgical boards, there's a certain rhythm to it.
A comforting rhythm, yeah.
Exactly. It's logical. You have symptoms, diagnosis, treatment plan, and usually, there's a clear pathway to a cure. It feels orderly.
It does.
Yeah.
Medical science, it likes order. We love algorithms. Step 1, step 2, step 3, cure.
Right. But today, we're looking at a topic that just takes that order, crumples it up, and throws it out the window. We're opening up clinical guides, surgical protocols, and pathology notes on a condition called Anaplastic Thyroid Carcinoma, or ATC. And honestly, reading through these files felt less like studying for a board exam and more like, reading the script for a horror movie. I said in the intro, if thyroid conditions were a video game, this is the final boss fight.
That's a vivid way to put it, but you're not wrong, clinically speaking. It is the boss fight.
Yeah.
In endocrinology, we spend so much of our time reassuring people. We talk about how manageable thyroid issues are. You have hypothyroidism. You take a pill, you're fine. Even papillary thyroid cancer, the most common type, has survival rates that are just incredibly high.
Often over 90%, right? That's the whole good cancer narrative you sometimes hear.
Precisely. But anaplastic thyroid carcinoma is the complete inverse of that. It is the most aggressive, the most lethal form of thyroid malignancy we know of. It accounts for a tiny, tiny fraction of thyroid cancers, but a huge percentage of the deaths.
And that's our mission for this deep dive. We need to figure out why. We've got the high-level guides here, and we have to unpack why this specific diagnosis changes the entire medical game plan so drastically. Because right off the bat, there was one fact in the staging section that it stopped me cold.
I think I know which one you're talking about.
Usually you learn Cancer 101. Stage I is early, localized. Stage 5 is widespread and bad.
Sure, the standard progression on its witty.
But the source material for ATC says, and I'm looking at the quote here, anaplastic carcinoma is always stage 4. There is no stage 1. There's no stage 2. It literally starts at the end. That
one rule is the defining characteristic of this disease. It completely skips the early warning phases. By the very definition, by the time a pathologist even looks at those cells under a microscope, the cancer has already reached a level of aggression that forces it into a stage 4 classification.
So it's not just a worse version of other thyroid cancers, it's a completely different beast.
A different beast entirely.
So let's trace that beast back to its lair. Let's look at the origin story. The notes use this term that comes up constantly, de-differentiation. It sounds super technical, but the explanation in the text makes it sound almost philosophical.
It is. It's an identity crisis, but on a catastrophic cellular level. To get it, you have to picture a normal thyroid. It's made of follicular epithelial cells.
The workers.
The workers, exactly. They have a job making hormones. They have a uniform. They look like little cubes. They follow the rules.
And most thyroid cancers, the manageable ones, they still sort of respect that, don't they?
They do. Papillary or follicular carcinomas are what we call differentiated.
Yeah.
You look at them under a microscope, and you can say, okay, that looks like a thyroid cell behaving badly. It still remembers where it came from.
But anaplastic is undifferentiated.
Backward formation.
Yeah.
That's literally what anaplastic means. The cell forgets it's a thyroid cell. It loses its structure. And here's the really scary part from the exam pearl section of your notes. ATC often represents the de-differentiation of a pre-existing thyroid cancer or even a long-standing goiter.
That was the Breaking Bad analogy I scribbled in the margins. You have this cell, maybe it's a slow-growing cancer or just a benign goiter cell. It's been sitting there for years behaving, and then snap.
Exactly. A genetic catastrophe happens. Usually it's an accumulation of mutations. PASH53 is a common one here. And the cell just loses its identity. It stops making thyroid hormones because that's not its job anymore. It has one new job, chaotic, rapid division.
The pathology report describes that chaos, and the visuals are pretty wild. They use the term highly pleomorphic.
Which is just fancy medical speak for all different shapes and sizes.
Right, but then they get specific. Giant cells, spindle cells. It sounds like a monster mash.
It looks like one too. Normal tissue looks like a brick wall, all uniform and organized. ATC looks like someone took a sledgehammer to that wall and then threw in some scrap metal. You see these monstrous, misshapen cells. And because they're growing so fast, you see another key feature mentioned in the notes, extensive necrosis.
Necrosis is dead tissue. But why is there dead tissue inside a growing tumor? That seems counterintuitive.
Think about why it's there. This tumor is growing so explosively that it actually outgrows its own blood supply.
Yeah.
It's building a city faster than it can build roads. So the center of the tumor literally starves and dies while the edges just keep expanding.
Wow, so that necrosis is actually a sign of its aggression.
A hallmark of it. It's growing faster than the body can physically sustain.
Okay, so we have a cell that's lost its mind, forgotten its job, and is growing faster than it can be fed. Who does this happen to? Because when I think of thyroid issues, Hashimoto's, Graves', it's often younger women.
That's the typical demographic, yeah, for the autoimmune issues.
Hmm.
But ATC profiles very differently. The source material points primarily to elderly patients, usually in their 60s, 70s, or 80s.
So a much older group.
Much older. There is still a slight female predominance, but age is really the biggest risk factor here. This is not usually a disease of people in their 20s or 30s.
And this leads to the clinical presentation, which I found to be the most practical, albeit terrifying part of the notes. If there are doctors or med students listening, this is the red flag scenario. The notes describe a patient with a long-standing goiter.
Right. Picture a grandmother. She's had a lump in her neck for 20, maybe 30 years. Never bothered her. Her doctors watched it. It's benign.
And then the source says sudden rapid enlargement.
That is the classic narrative. The patient comes in and says, "Doctor, I've had this lump for decades, but in the last 3 weeks it's doubled in size." That single sentence should set off alarm bells in every clinician's head.
Because that suggests the de-differentiation event has happened.
The slow, sleepy goiter has woken up and chosen violence.
The physical description of that new mass is distinct too. It's not soft. The notes use words like hard, painful, and this term that really stuck with me, skin fixation.
Skin fixation is exactly what it sounds like. Usually, if you have a benign cyst, you can push it around under the skin. It's mobile. ATC invades the surrounding tissue so aggressively that it infiltrates the muscle and actually grows into the skin from the inside.
It effectively glues the thyroid to the neck.
Feels like a rock. Hard, fixed, and immovable.
And a rock in that location is a huge problem. It's crowding out some very expensive real estate. The sources list hoarseness of voice as a major early symptom.
And hoarseness is sinister here. It's a sign of nerve involvement. The tumor is invading the recurrent laryngeal nerve, which controls your vocal cords. But as the tumor gets bigger, and remember, it grows rapidly, it starts compressing the esophagus and the trachea.
So you get dysphagia, trouble swallowing, and dyspnea, trouble breathing.
And eventually, you get the sound known as stridor.
Stridor. The notes describe it as a high-pitched, noisy breathing.
It's a terrifying sound. It's the sound of air trying to force its way through a pipe that's being squeezed shut. When you hear stridor in a patient with a neck mass, you are in a medical emergency. The patient is literally running out of room to breathe.
That brings us to what the guides call the immediate threat. Usually with cancer, the fear is systemic. Is it going to spread to the brain or the liver? And ATC does spread, but the source is so specific, the immediate killer is airway compromise.
It's a mechanical problem before it's a systemic one. Before the cancer has a chance to kill you via metastasis, it can kill you just by choking you. That's why the first priority isn't chemo or radiation, it's just securing the airway.
So walk us through the investigation. A patient comes in, elderly, rock-hard neck mass, trouble breathing. How do we confirm what we're dealing with? The notes mention FNAC.
Fine needle aspiration cytology. It's the standard biopsy. You take a thin needle, you poke the mass, and you suck out some cells.
Is that really enough? I would have thought you'd need a big chunk of tissue.
Usually for this, FNAC is sufficient. Remember those monster cells we talked about?
Yeah.
Because they are so bizarre and undifferentiated, you don't need a complex architecture to tell that something's very, very wrong. A few of those cells are usually enough to confirm it.
They'll also do CT scans of the neck and chest to see the extent. But there was this one grim note in the investigation section. It said, histology confirms the diagnosis, but does not change prognosis. That's a heavy sentence.
It's a very heavy sentence. It effectively means that knowing the exact cellular subtype, it doesn't unlock a magic door to a cure. Whether it's the spindle cell type or the giant cell type, the outcome is just as poor.
Okay, let's circle back to that StageIV concept, because I think that's one of the most unique things here. The source material was emphatic. Anaplastic carcinoma is always stage 5. But then, confusingly, they break it down into A, B, and C. If it's all stage 5, what's the difference? Why bother?
It's a way of describing how bad the stage 5 is. It's a scale of spread, which helps in deciding if we can do anything surgically. So stage IVA describes a tumor that is still technically localized to the thyroid area.
Okay, so IVA is it's here, it's bad, but it's contained.
Right. Stage IVB means it has grown outside the thyroid into the neck muscles, or maybe it's wrapping around the blood vessels. It's a locoregional invasion.
And IVC.
IVC is distant metastasis. It has left the neck.
Then where does it go? The notes mention hematogenous spread.
It travels through the blood. Most common spots are the lungs and the bones. And here is a stat from the source that really reinforces why we start at stage 4. Most patients already have metastasis at presentation.
Wow. So by the time that grandmother even notices the lump has doubled in size, it's likely already in her lungs.
Unfortunately, yes. That speed is part of why the staging system just assumes the worst from the get-go. It's not pessimistic, it's just being realistic about the tumor's behavior.
This leads us inevitably to management. And honestly, the tone of the source material it shifts here. It goes from diagnostic curiosity to almost resignation. The goal is palliative rather than curative.
That is the reality of ATC. With most cancers, we go in with curative intent. With anaplastic thyroid carcinoma, the primary goal is often symptom relief. We're trying to buy time, yes, but mostly we're trying to prevent suffocation, improve the quality of the time that remains.
One of the procedures discussed is the role of tracheostomy. A track seems like the logical fix for a closing airway, but the notes warn against it. They say it's technically difficult with a high complication rate. Why?
Think about the anatomy. To do a tracheostomy, you have to cut through the front of the neck to get to the windpipe. In a normal patient, that's skin, a thin layer of muscle. In an APC patient, what's sitting right on top of the windpipe? Exactly.
Yeah.
A massive, rock-hard, necrotic, bleeding tumor. To get to the airway, the surgeon has to literally cut through the cancer. It bleeds profusely. It's messy. The trachea might not even be where it's supposed to be. It's a surgeon's nightmare.
That makes sense. It's a roadblock. So naturally, the next question is, why not just cut the whole thing out? Why isn't a thyroidectomy the answer?
We wish it were that simple. The source material is very clear. Surgery is rarely curative. The reason is that the tumor invades everything so early. It grows into the carotid artery, the esophagus, the spine. You can't just cut those things out.
You can't get clear margins.
You can't. The cancer cells are already woven into the vital structures of the neck. So when surgery is done, the notes call it debulking.
Right, debulking.
We remove as much of the mass as safely as we can, not to cure it, but to take the pressure off the trachea so the patient can breathe. It's a mechanical solution to a mechanical problem.
And what about the other weapons? Radiotherapy? Chemotherapy?
They're used, often in combination. It can help shrink the tumor or at least slow it down. There are some newer targeted therapies for selected cases, like for patients with BRAF mutations. But these are essentially just trying to pump the brakes on a runaway train.
There was one crucial distinction in the treatment section I want to highlight, because for anyone who knows about thyroid cancer, this is going to sound wrong. The notes say this is not radioiodine sensitive. Why does that matter so much?
That is a huge blow. For papillary thyroid cancer, we have a magic bullet called radioactive iodine. Thyroid cells love iodine. It's their food. So we feed them radioactive iodine, they eat it up, and they destroy themselves from the inside. It's incredibly effective.
But we have to go back to that word, de-differentiation.
Precisely. These anaplastic cells have forgotten who they are. They don't have that mechanism to suck up iodine anymore. They just don't care about it. So if you give radioactive iodine to an ATC patient, the cancer cells just ignore it. Our best weapon is completely useless.
That really ties the whole picture together. The contrast questions section in our sources was framed for exams, but it's really a good summary. It's like a police lineup.
Let's run through it.
Suspect 1, papillary carcinoma.
The indolent one, lazy, grows slowly, spreads via lymph nodes, very treatable. This is the one you want to get.
Suspect 2, follicular carcinoma.
Spreads via blood, but still looks like a thyroid cell. More aggressive than papillary, but still manageable.
Suspect 3, medullary carcinoma.
The unique one, different cell type, secretes calcitonin. It's its own category.
And finally, the villain of our story, anaplastic carcinoma.
Defined simply by rapid and fatal. The expert commentary in the notes really emphasizes this. Speed of growth is the key differentiator. If a thyroid lump has been the same for a year, you can breathe a sigh of relief. If it doubled in a month, that's the danger zone.
We have to look at the numbers. The prognosis section is stark. The median survival isn't measured in years.
No, it's measured in months. Often less than 6 months from diagnosis. The 1-year survival rate is very low, often cited around 20% or even less in these guides. It's a diagnosis that prompts a discussion about end-of-life care almost immediately.
Which has to be so difficult for everyone because the timeline is so compressed.
Incredibly difficult.
The source material had a section on common exam traps, which I actually found was a really helpful summary.
The myth busters.
Exactly. Trap number 1. Thinking that because it's cancer, the metastasis is the biggest worry.
Trap busted. The airway is the first priority. A doctor who focuses on the lungs while the throat is closing is making a fatal error.
Trap number 2. Trying to stage it like other cancers.
Never look for a stage I anaplastic carcinoma. If you see stage I on a chart, it's not ATC, it's always stage I, period.
And trap number 3. Assuming surgery is the fix.
Surgery is for breathing, not for curing. That's the key takeaway.
It is a sobering topic, but to recap this deep dive, anaplastic thyroid carcinoma is the boss fight. It attacks elderly patients, often hijacking an innocent goiter. It hits fast, turning a benign situation into an airway-crushing emergency. It laughs at radioactive iodine, it starts at stage 4, and it forces doctors to shift almost immediately from trying to cure to simply trying to help the patient breathe.
It is a stark reminder of the biological chaos that cancer can represent.
It really is. And that brings us to the end of our source material. But before we go, looking at all these notes on cells losing their way, is there a final thought you want to leave the listener with?
We kept coming back to de-differentiation, the cell forgetting what it is. It raises this fascinating, if slightly terrifying, question about biology. We think of our bodies as these permanent structures. My thyroid is my thyroid. But ATC shows us that cellular identity is actually really fragile.
It's not a given.
It's not. It takes constant energy, constant genetic regulation for a cell to remember to be a thyroid cell. It's an active process. And when that regulation snaps, the default state isn't just nothingness. It's chaos. It's aggressive, primal growth. It makes you appreciate that right now, trillions of cells in your body are just dutifully remembering who they are and doing their jobs.
A delicate balance we take completely for granted.
Completely.
That is a profound way to look at it. We are all just a collection of cells agreeing to cooperate until one decides to break the contract. On that note, thank you for joining us on this deep dive. It's heavy stuff, but knowing it makes the machinery of life seem even more incredible.
Absolutely. Thanks for listening.
Catch you next time.